very much for inviting us to talk today. So this will be a kind of a freeway talk. So I'll talk for about 10 minutes and then Sara and Ian will do their parts. I'm going to just start by just giving a brief overview of the type of work we do. And then Sara and Ian will talk in more detail about a particular study within inflammatory musculoskeletal conditions. So the bit about the Keele Electronic Health Research Group. So it's based in the School of Medicine here at Keele. There's about 40 or so members, mixture of clinical and methodological researchers. So we have GPs, rheumatologists like Ian, physiotherapists, methodological researchers, statisticians, epidemiologists, social scientists, data manager, and so on. We do a lot of kind of national and international collaboration. So we're very keen on collaboration. So if anybody gets piqued with some of the topics we talk about today and would like to talk about collaboration, then please do get in touch. We did a lot of studies using the Clinical Practice Research Data Link. So we have about 80 publications, I think, which has used CPRD. And most of the examples I think we're going to give today will be based in CPRD. But we also have used local primary care data. We've also used other databases such as UK Biobank. We've also, within our kind of population surveys and trials we do within the School of Medicine, we've linked self-reported data with consent to electronic health records. So that kind of brings together the self-reported patient outcomes and management of processes of care, which is very handy. We have a main focus on musculoskeletal conditions, and that's probably what we're most known for. But just to say, we do stray a little bit, particularly mental health and cardiovascular. So what I'm going to do is just give a couple of examples, first of all, around mental health and cardiovascular, before I move on to the musculoskeletal work that we do. Okay, so to start in mental health, so we've done a couple of studies now in dementia. So I'm not sure how much you're aware of dementia research, but a lot of dementia research looks at kind of long-term outcomes such as care home admission or mortality. But we reason there may be possibility of kind of looking at more early indicators of progression of dementia, which may be available in primary care records. So we did a study in CPRD, and this kind of diagram shows you all the kind of indicators which may be available in primary care, which may indicate progression of dementia. And the study we showed is, the study we did showed that basically the more of these markers you have in the first year after diagnosis, the increased risk you have of things like hospitalization and early mortality. The premise being that most of dementia is actually managed in primary care. So that may be where you get kind of a lot of the markers of progression. We've also done studies in psychosis. So this is looking at kind of prodromal symptoms prior to diagnosis of psychosis. So in this study, we took patients with a diagnosis of psychosis and looked back 5 years to see what symptoms they presented with. And then we did a cluster analysis, well, latent class analysis, to cluster patients into clusters based on the symptoms that they presented with. So basically on the graph on the left, you had a cluster of patients who basically presented with very few symptoms before diagnosis. The middle group, they presented with effective symptoms for up to in the 5 years prior to their diagnosis. And then you had a group at the end who presented with multiple symptoms across many different types in the 5 years before diagnosis. And one of the kind of striking things from this study was that many patients were presenting up to 5 years before their diagnosis with symptoms relevant to psychosis. We also have kind of a strong cardiovascular theme, and this is led by Professor Mamas here at Keele. So Mamas kind of leads a lot of cardiovascular research, much of which is big data research. So that includes use of American data sets, so hospital data sets, health insurance data sets, but also UK primary care and secondary care data sets. And I'm just going to give one example of cardiovascular research that I've been involved in. So this is looking at patients who presented to primary care with chest pain. So 2% of adults present each year with chest pain to general practice. Most of them don't actually get a diagnosis. Cardiovascular causes ruled out. Some are attributed to things like anxiety or musculoskeletal condition or respiratory condition. But most people with chest pain don't actually get a cause for that chest pain. So what we've done in a series of papers is show that people with this kind of unattributed chest pain have a higher long-term risk of cardiovascular disease over the next 10 years than people who get, say, an anxiety cause or a musculoskeletal cause or a respiratory cause for their chest pain. We've also shown that the ones who are probably most at risk of cardiovascular disease aren't really being managed appropriately in terms of prevention. So very few are actually getting statins to try and prevent cardiovascular risk in the future. What we also did was kind of look at the performance of Q-risk. So for those of you who don't know, Q-risk is a recommended prediction tool for use in general practice to predict long-term cardiovascular disease. And it was derived and validated in the general population. So we tested this out in patients with unattributed chest pain in primary care. And you can see from the calibration plot that Q-risk essentially very much underestimates the risk of cardiovascular disease over the following 10 years, mainly because it was developed and validated for the general population, not with people with chest pain. And so we developed an externally validated new model to predict cardiovascular risk in people with unattributed chest pain. So moving on to kind of musculoskeletal research. So we have kind of, I guess, 4 main areas where we do research. So there's surveillance. So we look at kind of incidence and prevalence of musculoskeletal conditions over time and how that's changing. The quality of care and how that's changing over time. Similar to the psychosis study, we look at kind of prodromal factors and risk factors for musculoskeletal conditions. We looked at adverse events of some management of musculoskeletal conditions. So for example, we've done studies around long-term opioids and the risk of adverse events for people prescribed opioids. And we also look at outcomes of musculoskeletal conditions and what are the factors which predict poorer outcomes, including risk prediction models. So I'm just going to give you a couple of examples of these now. So these are just some of the papers kind of related, first of all, to some of these areas of interest. You can see we kind of cover the whole range of musculoskeletal conditions like back pain, osteoarthritis, gout, rheumatoid, polymyalgia rheumatica, giant cell arteritis, and so on. So in terms of specific examples, so this is a study which looked at incidence of back pain and osteoarthritis using CPRD over time between 2004 and 2019. And we kind of split it down by deprivations, this neighborhood deprivation. And you can see there's kind of persistent inequality in incidence of both back pain on the left and osteoarthritis on the right, much higher rates of back pain and osteoarthritis in the most deprived areas, with the least deprived areas having the lowest incidence. And this is kind of consistent and maintained over the 15 years that we did the study. And I think Sara will be talking in more detail about kind of incidence of inflammatory conditions in her presentation. We've also done kind of prediction models. So in this study, we took patients who presented for the first time with knee pain or knee osteoarthritis and developed a prediction model to predict the risk of a total knee replacement over the next 10 years, using the clinical practice research data link. And similarly, we've done a similar prediction model for patients presenting with hip pain and hip osteoarthritis, examining the risk of trying to predict the risk of total hip replacement over the following 10 years. And all the predictors are basically information recorded in the primary care records, including both the sociodemographics, healthcare use, and the management. So this is a slightly different study, and Sara can probably give you more details of this if you're interested later. But this is looking at management of gout. So patients newly diagnosed with gout often are given allopurinol, but allopurinol does take a little while to work. And there can be kind of acute flares of gout in the meantime in the short term. So patients are often given colchicine to try and combat these acute attacks of gout. However, there are concerns around the safety of colchicine. So this study basically compared patients with gout prescribed allopurinol and compared those who were given colchicine to those who were not given colchicine within CPRD. And I guess a couple of nice methodological parts were, first of all, did propensity score matching to match patients with colchicine to those without colchicine. And then they basically used both the CPRD Aurum and the CPRD Gold data sets. So for those who don't know, CPRD has 2 data sets, gold and aurum, and they did the analysis separately in each of those 2 data sets, and then use IPD approaches to combine the 2 analyses to get the overall hazard ratios. And what you can see here is basically there's an increased risk of most of the adverse events, so diarrhea, neuropathy, bone marrow, myalgia, etc., in patients who were given colchicine compared to those without colchicine. And I think that paper's just been accepted for publication. Just something slightly different to end up with from me. So this is a local study where we've kind of linked self-reported data to electronic health record data called MIDAS. Essentially, we've done, or we're in the progress of doing 3 different types of survey. So we're surveying consultants for musculoskeletal pain across 30 local general practices in North Staffordshire. We've also done a survey of a random sample of the general population from the same 30 practices. And we're also surveying people consulting first contact physios or musculoskeletal community services. And so the outcomes are self-reported, so it's got lots of musculoskeletal health measures, but we're also asking for consent to link to their primary care records, so we can match a person-reported outcome to the management and the processes of care. And the idea being that we can model variation in inequalities of musculoskeletal health across North Staffordshire. And just to give you an idea of kind of what we're hoping to end up with, so this is a map in North Staffordshire. This is actually from a previous study, but we've actually tried to estimate the prevalence of high impact chronic pain across North Staffordshire. And for those of you who know North Staffordshire, probably won't be surprised to hear that this kind of area in blue is Stoke-on-Trent, and that's where the highest prevalence of chronic pain is. And the lower prevalence is kind of in the Staffordshire Moorlands, the kind of northeast of Stoke-on-Trent. So what we're trying to do with this study is try and kind of do similar maps around the kind of prevalence of chronic pain and musculoskeletal health, but kind of overlay it with how patients are presenting to primary care and the management that they receive. So you get both the kind of patient outcome, but also the kind of management, and it can compare the 2 kind of graphically. So that's kind of all from me. So I'm going to stop sharing now. And I'm going to pass over now to Sara, I think, who's going to be carrying on from this point.
Yes, me next. I'm just going to make sure I've got this right. Press the right buttons. Can you see?
Yes, thank you. Thank you, Sara. Yeah, that's fine. Thanks.
Great, thank you. So, hide myself so I can see what we're doing. So, yeah, thank you. I'm going to talk about some work that Ian was leading and I was involved in, where we were looking at the epidemiology of inflammatory arthritis in CPRD aurum. So first of all, for those that don't know, what do we mean by inflammatory arthritis? And we're using it here as an umbrella term for conditions causing autoimmune joint inflammation. So 3 types we considered were rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis. If you need to know anything more about the clinical side of those, I think Ian would be a better person to discuss that with. But they're important because they have substantial costs in terms of pain, disability, sickness, absence, and also potentially high NHS costs with some of the newer treatments for these drugs, the biologic disease-modifying anti-rheumatic drugs. And understanding the epidemiology of these different conditions that contribute to the category of inflammatory arthritis is important so that we can make sure that services are properly configured and deliver early treat to target care, which we know makes a difference to long-term outcomes. And this piece of work was the first in a much larger programme of work, and Ian's going to talk about the next study in this work next. But what we wanted to do was have a reliable way of establishing in the primary care record who had inflammatory arthritis. And that's been done before, particularly for rheumatoid arthritis. but it was done in CPRD Gold quite a long time ago. Treatments have changed. And also the thing to note with inflammatory arthritis is that these patients are all seen in secondary care. So although we'd expect the diagnosis to be recorded in primary care, they're all managed in rheumatology. So there are, as I said, previous studies in CPRD Gold, and there was a study in Thin for ankylosing spondylitis, which is a part of the group, the final group I mentioned of axial spondyloarthropathy. And there were sort of varying degrees of complexity to how these conditions had been defined previously. So for RA, there was a fairly complex algorithm that had been developed in CPRD Gold, and then I actually updated it in a different piece of work, probably about 8 years ago now. But that was again still in CPRD Gold. And then for AS, it was a much simpler algorithm where it was just a case of having 2 codes at least 7 days apart. And for psoriatic arthritis, it was just a single read code in the record that's been used previously and found to have a good positive predictive value. So we were starting from that point, but wanted to make sure for our programme of work that we knew that we were using the best definitions we could. And so we updated the diagnostic algorithms and code lists with SNOMED codes as far as we could, based on previous work. So for the rheumatoid arthritis study originally, the researchers who were based in London had done an actual review, or had GPs reviewed the medical records of those patients, which we weren't doing again this time. This was just updating the definitions they'd been using with the codes that are currently available in ORAM. So as I said, we're using ORAM, which I think Kelvin's already mentioned, but it's the larger part of CPRD, with about 20% UK coverage at the moment. And the aim of this study was to update those algorithms and then to estimate the annual incidence and the point prevalence of rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthropathy. So for RA, which was our complex algorithm, you can see there the definition in the blue box. I hope you can see it. It's probably fairly small. But it was a sort of 2-part criterion, and I'll show you how that worked in a little while. So you could either have a diagnostic code for RA and at least one appropriate DMARD, or disease-modifying antirheumatic drug prescribed, or you could meet all 3 of the sub-criteria of having 2 or more read codes on different dates, no alternative diagnosis that might explain the RA symptoms. So you've not had your diagnosis, doesn't look like you've had your diagnosis of RA changed to something else. And you had at least one, what was called a strong code for RA. So something like, say, seropositive RA, rather than a code to say you've had an RA review, for example. And we reviewed all those code lists, all the alternative treatments for all the alternative reasons you might have received DMARD treatments. It's a huge bank of codes, and they were all agreed by 2 clinicians before that algorithm was applied in ORAM. And then much simpler for axial spondyloarthropathy, it just had to be 2 codes, and there were only 5 of them. And then for PSA, or psoriatic arthritis, there were 6 codes, and an individual just needed to have 1 in their record in order to be included in the study. So the sample was our permanently registered patients aged over 18 at their first inflammatory arthritis code, and they were contributing to ORAM between 2004 and 2020. 2020 because that's when the data were extracted, 2004 because that's when biologic drugs were introduced, which really changed the management of inflammatory arthritis quite dramatically. So it's a different landscape to pre-2004. We reported annual incidence per 100,000 person years for each of the inflammatory arthritis types separately. And we define that as individuals registered during that calendar year, never having been coded as inflammatory arthritis before. I'm saying this for RA, but we did the same thing for PSA and axial SPA as well. So they've never had a code before, never had a code before, And in that calendar year, they received their first code. So we also looked at point prevalence, and we've reported that as a proportion of the population in each year who had a code for that condition during that time period. So onto the results, which are the more interesting bits. You can see for rheumatoid arthritis here, I've got a couple of different pictures. So in the first, in part A of that graph, you see we've got the top line in blue is meeting the algorithm at all, and that's per year. You see it increased until about 2012 and then tailed off slightly. Those people first satisfying the definition at that time. The red line is criteria 1, which is the 1 RA code and a DMARD with no other reason to have been prescribed that drug. And the green line is the criteria 2, so they're having more than one code, strong code. And we see more people met the algorithm definition of RA within those with an RA code via criteria 2 than via criteria 1. And although there was a slight trend over time in terms of how many people met that diagnostic algorithm, or what proportion I should say, it was always criteria 2 that was more readily met. And you can see the bits in panel B that contribute to that second criteria. So more or less everybody has no alternative diagnoses, but the number with 2 or more SNOMED codes increased over time, while the number with, or the proportion, I should say, sorry, with a strong code decreased slightly. And we think that coincides with the introduction of the quality outcomes framework for rheumatoid arthritis. And I see that again on the next slide. You see there in panel C, the number of people meeting our definition of axial SPA, so having 2 or more codes at least 7 days apart, was fairly constant over time. And that was around 60% of people who had at least one axial SPA code. So on to the incidence and prevalence figures. You can see that for RA, the rate of RA diagnosis up to about 2013, when RA was introduced into QOF, was about 40 per 100,000. And then there was quite a big increase at the time that it became part of QOF. And that's to do, we think, with changes in coding practice, not changes in the actual incidence of RA. And then in 2020, with the pandemic, we can see there's a huge drop-off in the rate of incident RA diagnoses, which is what we'd expect when perhaps access to care was not as straightforward as it had been in previous years. But with this prevalence, we can see in the bottom graph that there's just been a steady increase over time, and that sort of slightly flattened out in 2020, which is probably to do with the lack of new incident cases. And the results are very similar in terms of incidence and prevalence to what was seen previously in CPRD Gold and in another study in Aurum. And then similarly, we've got psoriatic arthritis. We can see the drop-off of COVID with the pandemic, and the classification criteria were introduced in 2006, which does seem to have had a slight impact on the incidences increased slightly. Again, similar to what we've seen in previous studies. Then for axial SPA, again, very, very similar patterns. Introduced classification criteria seems to be associated with an increase in incidence, and we've got a drop-off in the pandemic. What's clear, I think, in all 3 conditions making up our definition of inflammatory arthritis is that there's been an increase in incidence and prevalence over time. What we don't necessarily know is whether that's an increase in numbers of people or a difference in coding, but it does seem likely it's probably a real increase. We have now developed and have available systematic, reproducible approaches to defining all 3 types of inflammatory arthritis, and we're using this now in our ongoing studies. it's worth noting, though, that we didn't have access to the full medical records. So although we've updated those code lists, we've not been able to compare them to medical record notes, because that's not something we can do easily in CPRD. I don't know if we'd be allowed to do it at all now. We don't have data on biologics, so although we've restricted the sample to more recent data since biologic drugs were introduced, those are prescribed in secondary care, and we don't have that data in the CPRD. And there was a substantial minority, so not much less than half of people with a single code for axial spondyloarthritis who didn't have a second code, and so didn't meet our algorithm for inclusion. So we do think these algorithms now support us using these definitions in primary care, and Ian's going to talk about the next study we did doing that. But it's very clear that QOF, classification criteria, and COVID-19 all had an impact on the recording of inflammatory arthritis in primary care. But we saw the kind of patterns we'd expect to see in terms of gender. I should have said, sorry, that we also looked at all those incidence and prevalence figures by age and gender and saw exactly what we'd expect to see, which is reassuring. And as of 2020, over 1% of the population of England has a diagnosis of one form of inflammatory arthritis or another, which really does underline the importance of looking at inflammatory arthritis to optimise care. So just have to highlight, this study was funded by Ian's Advanced Fellowship, which I think he might tell you a little bit more about in a minute, and just the CPRD disclaimer. So thank you very much. Right, stop sharing. How do I do that? Oh. Sorry, I've lost Zoom.
Sorry, it should be at the bottom.
I've not got anything. Where's it gone?
Or is it maybe at the top?
I've only got people, I've not got buttons.
The other option, I think, is that Ian can come on and start sharing his screen, which I think will automatically stop you sharing yours, so you can race to find the buttons.
I'll give it a crack.
Yes,
I got the button.
Give it a go, Ian.
Yeah, it's gonna override you.
Oh, it's up there. I found it. It's moved. It's on my other screen.
It's hard, isn't it, when you're not used to one of the systems? I really hope I've got the right presentation up as well. I'll just have a very quick look. Yeah, that looks right.
Brilliant.
Can everyone see that and hear me okay?
Yeah, that's good.
Yeah, fantastic. So thanks, Kelvin and Sara. Two great presentations, and hopefully I'll be able to maintain the standard of the presentation. I'm going to focus maybe a little bit more of a clinical issue, building on the work that Sara presented, which is looking at how analgesics, so painkillers, are prescribed and the variation within that in people with inflammatory arthritis in CPRD aurum. Pain is the main problem that patients with inflammatory arthritis report when they come and see me in clinic. And patient surveys across multiple countries consistently show that most people suffer daily pain, and it's the area of their health that they most want improving. And pain care requires two broad things. Firstly, something called treat to target, which Sara mentioned, and that's where we use these specialist drugs called DMARDs like methotrexate and biologics to measure joint inflammation and reduce it until we achieve this target of remission from disease activity. But that doesn't resolve pain, and biopsychosocial care is also important, particularly non-drug care. We know from trials that things like exercise are safe and help improve pain, and obviously have numerous other benefits. With regards to analgesics, there's very limited evidence they have small effects, if any, and particularly for opioids and gabapentinoids, there's no trials of long-term use. But we know that these drugs have many potential harms and is a major cause of hospitalization, adverse events from opioids and NSAIDs within England. Despite that evidence base and these potential harms, studies have shown that opioids are widely prescribed, people with inflammatory arthritis. So in North America, which is admittedly a very different healthcare system, 40% of people are chronic opioid users in healthcare insurance database studies. And in the Australian Biologics Registry, so this is people receiving what's considered gold standard care with these very high cost biologic drugs, which cost around £10,000 to £15,000 a year. 1 in 3 people were opioid users. In the general population across England, we know that opioids and gabapentinoids are more often prescribed to people of older, deprived areas and of female gender. And that probably stems from these groups having more chronic pain. But there's 2 uncertainties in inflammatory arthritis, which we wanted to address with this study. And that's firstly, to understand the extent to which non-opioid analgesics are prescribed. There's been a big focus on opioids, but what about gabapentinoids, which are now controlled drugs? There's concerns around harms of dependency now. And what about NSAIDs, which are arguably a far higher risk drug than opioids? And also the extent to which this prescribing variation applies to people with inflammatory arthritis in England, and whether or not there's any potential unfairness in the care people are receiving. And this research therefore has 3 aims. Firstly, to define the annual prevalence of analgesia prescriptions in people with inflammatory arthritis. Secondly, to look at how this varies by certain patient factors, for example, arthritis types, age, gender, deprivation, and where people live. And the final one is to determine prognostic factors present when someone presents with a new diagnosis of inflammatory arthritis in primary care for the subsequent receipt of a long-term analgesic prescription. And the population is basically the same population as Sara discussed in our epidemiology prevalence work within CPRD Aurum. So I won't go into that in detail. In terms of methods, this is actually a series of studies. Firstly, a series of cross-sectional studies looked at the annual prevalence of analgesia prescriptions in each calendar year in inflammatory arthritis overall and by types per 100 person years at risk. And within that, the numerator was people with at least 1 prescription for the analgesic during the year, and the denominator was people with inflammatory arthritis on or before the end of that year. And we reported this stratified by arthritis types and also the other variation factors that I mentioned, like age and gender. And that addressed aims 1 and 2, but aim 3, the prognostic factors, we conducted cohort studies where we developed cohorts of people with incident rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis. And we used Cox proportional hazards models to test the associations between what we hypothesized were prognostic factors for long-term analgesia prescriptions with the outcome of time to receipt of a chronic prescription for opioids, NSAIDs, and gabapentinoids separately. And we defined a chronic analgesia prescription as at least 3 prescriptions over a 90-day period, which sounds quite simple in practice, but it's one of the most complex things that you can actually do in the CPRD, dealing with prescription data of that nature. And we adjusted for age, gender, and body mass index to look at the prognostic kind of power of these different factors beyond those simple prognostic factors that we already know are important. I'm now going to present the results, and this all have graphs of a very similar nature, where along the x-axis we have the time in calendar years. It actually starts in 2004 up until 2020. And along the y-axis, the annual prevalence of prescriptions per 100 person years. And within this figure, we've got it stratified by all inflammatory arthritis in yellow, rheumatoid in red, psoriatic arthritis in green, and axial spondyloarthritis in blue. I'm very sorry, I don't know how to sort Zoom, so I haven't got the bit at the top blocking everything up. But I think this is yet variation by inflammatory arthritis type. And we've broken it down by any analgesics, basic analgesics, so things like paracetamol, any opioid, oral NSAIDs, and gabapentinoids. And that's a hierarchical analgesic classification system developed by academic GPs at Keele, led by John Bedson. And the first, perhaps most important message is that lots of analgesics are prescribed. They've fallen a bit over time, that's modest. So in 2020, for all inflammatory arthritis, any analgesic prescription is 64.5 per 100 patient years. We also see changes in the types of analgesics used over time. So in 2004, NSAIDs were most prescribed, However, this fell quite a lot over time. So it's by 2020, opioids were the most prescribed, 39 per 100 patient years. You can see that gabapentinoids has edged up. Opioids has fallen a bit, but gabapentinoids has probably just replaced that. We also see that there's more non-NSAID analgesic prescriptions in people with rheumatoid arthritis, particularly opioids. These now show variation by people's age and gender. And panel A is age, and it's the same structure, but this is for all inflammatory arthritis grouped together. And we stratified by age categories, going from less than 35 in yellow, then up in 10-year age bands up to more than 75 in brown. And in panel B, this is stratified by gender, males in red and females in blue. And I think the key finding is, particularly for age, that the prescribing of all forms of non-NSAID analgesics, so basic analgesics, opioids, gabapentinoids, just goes up with age. And if anything, that difference between the highest and the lowest ages is widening over time. So in 2020, prescribing was 80% more in the oldest versus the lowest age categories. And that's particularly concerning because as people get older, they're far more likely to have an adverse event from a drug. And we also see the same pattern for non-NSAID analgesic prescribing in females. And that difference by gender is really seen across all studies that look at analgesic prescribing. We see the opposite pattern for NSAIDs, which is really what we'd expect with age, because we tend to be quite cautious around prescribing NSAIDs in people that are older with comorbidities such as renal disease and cardiovascular disease. This now looks at variation in prescribing by deprivation. And what we've done is we've used IMD quintiles as a measure of deprivation. I accept its limitations, but it's what we have access to within the CPRD. And CPRD actually does quintiles deprivation the opposite way around to everywhere else. So quintile 1 is the least deprived, and quintile 5 is the most deprived. And this is for all inflammatory arthritis, panel on your left. And the key message here is that the annual prevalence of non-NSAID analgesic prescriptions goes up with deprivation quintiles. In 2020, the prevalence is 28% higher, rated the highest compared with the lowest quintiles. But interestingly, for oral NSAIDs, we don't see that variation. You can see very similar prevalence of analgesic prescriptions across the quintiles. And we hypothesized that that may be related, or certainly Kelvin hypothesized that, with an interaction between age and gender deprivation levels. And therefore, we explored that as much as we were able to do by repeating that analysis stratified by age categories, as you can see in the right, and deprivation quintiles. And that does show there is an apparent interaction in that the same pattern is seen in the younger age groups. So annual prevalence of analgesic prescriptions is higher, for NSAID prescriptions is higher in quintile 5 compared to quintile 1. But then that pattern switches as people get older. We think that's probably arising from the fact that as people age, if you're more deprived, you may develop more comorbidities, including the prescribing of NSAIDs, although that's just a hypothesis that we can't disprove within the data that we have. This shows variation in prescribing by geographical region. CPRD, I think, has 13 geographical regions, and we broadly group them into North, Midlands, East, and South. And what you can see here is that there's a clear North versus South divide for non-NSAID analgesics. So if you live in the North, you're more likely to get an opioid, gabapentinoid, a basic analgesic. But that pattern between North-South is not seen for NSAIDs. And again, that's presumably tied up between the interaction with deprivation and where people live. But it's one thing getting a one-off analgesic prescription at some point during the year. It's quite another getting a consistently kind of being prescribed long-term analgesics. What about the annual prevalence of chronic prescriptions? So we've looked at that, and this graph shows that for opioid prescriptions using the definition I mentioned before. And the key message is that most opioid prescriptions are chronic, and around 1 in 4 people in each year with inflammatory arthritis gets a long-term opioid prescription, which is highly concerning when you consider there's absolutely no trial evidence that they're effective in that way. My clinical experience is they don't work if used long-term. And what about that aim-free? I think it was actually, it's not possible within the scope of this short presentation to give you, go into detail in that, but lots of prognostic factors were found associated with long-term prescriptions. But what I'd like to focus on here in this slide is the relationship with deprivation. What we have here is hazard ratios for time to long-term opioid, gabapentin, and NSAID prescriptions by IMD quintiles. 1 is the reference least deprived to 5 to most deprived. And the key message here is that, as we saw with the cross-sectional data for opioids and gabapentinoids, deprivation, increasing deprivation increases your hazards of receiving a long-term opioid and gabapentinoid prescription. However, for NSAIDs, the association is a lot less clear. You see for quintiles 2 and 5 compared to quintile 1, the confidence intervals span 1, so they're not significant. So in conclusion, analgesics are widely prescribed in inflammatory arthritis, which is at odds with the evidence base. We found that for non-NSAID analgesic prescribing, it's common in certain groups of people, suggesting inequalities in pain and or pain care. But interestingly, we don't see that for NSAIDs. In terms of research agenda, I think we need to understand why this is happening, why analgesics are so widely prescribed, and why this variation is happening. And that's forming part of my NIHR fellowship, where we conduct something called the Pain Path Studies, which I'm happy to talk to anyone about further down the line. And that's in collaboration with the organisations listed here. I'd like to acknowledge all study co-authors, particularly Becky Whittle, who led on this statistical analysis, and Sara's already mentioned acknowledgements around my fellowship and the CPR disclaimer. Thank you very much.